Holsinger is an honorary laryngologist tonight. He's a head and neck cancer surgeon at Stanford, but he cares about the larynx and about function. And so we're happy to have him. Melda.
Thank you, Andrew.
Absolutely. Dr. Kunduk, PhD speech pathologist, who is my partner, who has a significant interest in swallowing and rehabilitation in head and neck cancer patients. He's graduated a few PhDs doing this. And Heather Starmer, our West Coast star that Chris recruited from Hopkins to start their team as well. And also, my partner Lacey Adkins is helping us manning the phones and questions. We're going to hold questions till the end, and Lacey and Allison will be fielding those and helping us get it. They will keep a running list on that, and if anything we don't get to, potential answers later, okay? So, want to get this on your mind, the Fall Voice registration is open. We're looking forward to seeing everybody in Dallas. I know all the crew has been working very hard on the program, and it looks very exciting. So we hope to see you there. The next thing they wanted me to bring up is this really neat new program that they have. This is an open discussion forum that you can sign up for. Once you've done it, you get access from Fall Voice for 2 years after attending. And what's neat about this is a discussion forum, post job ads, talk about, pose questions to people regarding tough cases, something like that, making colleagues, collaborate across the country. A really neat resource for us to have a venue to do this that actually wants us online doing this. So a great new added addition from Doc Matter. So why are we talking about this? So head and neck cancer is real. Like I said, it's a little bit of an aside from what we think about as laryngologists, maybe not so much with a speech pathologist, but it is a significant problem in our world today. If you look at the dark blue, these countries have over 11 cases per 100,000. Here in the US, we are about 1 in 10,000. And it's an epidemic in the developing world, in China and India, with the rising, burgeoning middle class, higher and higher rates associated with American tobacco. We're going to go through this from a little bit of a different standpoint. When we talk about maximizing voice and swallowing function in head and neck cancer, pretty much people are thinking that we're going to only talk about chemoradiation therapy. But with Chris and me involved, he and I are both very interested in conservation laryngeal surgery and other minimally invasive transoral approaches. And so we're going to put a little bit of a spin on it, dealing with some laryngeal cancer, as well as TORS. Chris is one of the leading experts in the country on this. And then we will get to organ preservation therapy. And Heather and Melda are going to keep us on task and help us really talk about the ins and outs. So the first thing when we think about managing head and neck cancer is a team. And so our scrub nurse drew this picture for me about everybody trying to get the patient to the other side through this journey. And there's a lot of people involved. And building this team is so important. Chris certainly recognized that with recruiting Heather, and they have done some studies on this. And just wanted to, real quickly, if Chris or Heather, if you guys would pipe in about team building, the components and recommendations of doing this in your cancer center.
Sure. So I got to Stanford about a year after Chris. And he and I were in discussions before I came to Stanford about sort of how do we want to build this and what are the components. And so, we all recognize the physician pillars of the multidisciplinary team, the surgical oncology, medical oncology, and radiation oncology members of the team. But for, modern best services for our head and neck cancer patients, we need to be thinking beyond just the physicians and including the rehabilitation arm. So that would include the speech pathologist, in many cases, physical therapy or occupational therapy for some of our flat patients from a perspective of doing things like splints, but also lymphedema management is becoming increasingly valued as a huge component of the head and neck cancer team. And then there are other providers like your image showed, dietary, nutrition, nursing. There are so many different people that are really involved in this. And so I think that it takes a very intentional and thoughtful approach to identifying who are the kind of the key members of the team who are advocates for this multidisciplinary approach, and then showing everybody else the value of it. So this study was one of the things that I did when I first came to the team, because I wanted to be able to show our own team, people who perhaps hadn't had exposure to speech pathology being integral in the head and neck cancer team, but also for other people who were dealing with similar situations. So looking at our patient satisfaction. And so our patients had better outcomes as well as better satisfaction with their function if they had a speech pathologist involved in their care from the beginning. So that was sort of the point of this paper, was really to demonstrate the value of integrating the rehab program into the main portion of the head and neck team.
Well, thank you, Heather, for that. And thanks again, Andrew, for the opportunity to be here. I think you really can't do this kind of surgery and really manage any kind of multidisciplinary program well without the speech language pathologist. And I was very lucky to have spent a lot of my career at MD Anderson, where there's a really strong program there, and also close proximity in the clinic with the surgeon, the patient, the other specialties, as well as that speech language pathologist. And that was a really important part, I think, of our success at Stanford. And I love how Heather found a way to really write a nice paper up about this. So I don't have much more to add than to what all the great things you said, Heather.
I think that was key, what you said, though. It's not just as a collaboration, as a team that you and Heather alluded to, but the embedding. So you guys are in the same place at the same time, seeing these patients and helping them make get better. That's invaluable with the cross-pollination of ideas and really knowing what's going on with the patients.
It's absolutely essential to have everyone co-located, and also I think it can be, it's one way, I think, where in a cancer center environment, otolaryngology and head and neck surgery can really, I think, set a standard for other collaborative disciplines. So it's really that co-location and close collaboration that really facilitates quality of care.
Chris, I think the one thing we're going to talk, a different spin on it, is also the role that laryngology has, with the expertise that the laryngologist brings to this in concert with the speech language pathologist, because not every head and neck cancer specialist is in tune to these functional outcomes. I think it's much more of a burgeoning field, but it certainly gives a different perspective, and it's sometimes a different skill set that's complementary between the head and neck cancer surgeon as well as the laryngologist and the speech pathologist and the rest of the team. So.
Absolutely. And I always like to say, I did my head and neck fellowship, and then I did some time in Europe abroad as my second fellowship. And my third fellowship was my continuing friendship with Andrew McWhorter, who gave me an honorary laryngology fellowship degree. So thank you for that, Andrew.
Yeah, thanks, Chris. All right. So we're going to, like I said, we're going to break stride with what people are anticipating, and we're going to talk about laryngeal cancer. Okay. And we're going to go for the most common things that laryngologists are treating: early glottic cancer. Okay. Very straightforward story on this lady: T1A, squamous cell carcinoma, smoker, no symptoms aside from dysphonia for 4 months, drinker, COPD, pretty typical. And I've got to move these to the bottom so I can actually see my, this is the voice sample here.
The rainbow is a division of white light into many beautiful colors.
Okay. And then, we can stop this and we'll start over here. So standard flexible laryngoscopy. I didn't show the best movement. Looking at this lesion extending from posterior third to the anterior third. Any thoughts on that, Chris, in terms of concerns? What your thought process is in terms of this? Chris, you got me?
Yeah, can you hear me now?
Yeah.
Yeah, absolutely. So seems like from a cancer standpoint, it seems very localized. There doesn't seem to be a lot of field effect, which I think is also really important when you're thinking about potentially minimally invasive surgery. This really looks localized. It also has that appearance of more of an exophytic lesion, which I think is more amenable to excision. And those are the two first things that sort of come to mind, just taking a look at this brief video.
Heather, Melda, any questions or thoughts, or when you see this guy in the office and you're doing the exam based on this lesion, of something you're concerned about?
Well, for me, really, first I wait for the surgery, and then after the first visit, you know, after talking with you and see what is the healing process and start from there.
Right. So we're counseling these people. We know that voice is unpredictable. We have high local control rates, you know, alternative radiation, equal oncologic outcomes, higher laryngeal preservation rate. Voice is, you know, depending upon the depth, determined in terms of what we get. Heather, any other thoughts?
Yeah, I think the only other thing I'd be thinking about or asking about at this stage is sort of trying to get a sense for the patient and what her vocal needs are, what her vocal demands are on a normal basis, as part of that preparation for what the outcomes would be.
Absolutely. And the person who's a voice professional, you're going to have a higher predictable outcome with radiation over surgery, you know, I think is an honest statement, and you have to counsel the patient to that. Chris, I'm going to play on, we're going to cut into a surgical video here a second. And so a 0-degree exam, it's a little bit more endophytic than it looked. 70-degree, you know, checking out this ventricle, what's the extent? You know, I like to, here's looking through the microscope, that's a 3 mm right angle. You know, I like to, the concept of the macro to the micro, you know, palpation, feeling, seeing what we're getting here, and just knowing exactly what we're dealing with.
It's a really nice view, especially that 70-degree. It's remarkable how different it looks in the office, even with a high-quality video strobe, and then what you see here. And talk about how that felt relative to the underlying ligament when you were palpating that, Andrew.
It's going into it. It's full. You know, I'm palpating lateral to it, making sure that I feel like I've got space between the cartilage and the vocal fold that is going to give me a boundary that I feel comfortable with for that margin. You know, what is this endophytic component like? How fixed is this? What does it feel like it's doing? So, Chris, I'm gonna, you know, I'm a splitter here. Would you excise this thing straight on, or would you cut in half?
You know, I trained with Steiner. I believe in that technique. I still take these things out whenever possible en bloc so that I can understand those relationships surrounding anteriorly, posteriorly, medial, laterally. I'd probably try to take it out en bloc.
Oops. Let me, well, you know me. So
you gotta go.
You know, it's old dogs that start to learn new tricks. I'm a huge believer in splitting, and I know that's become not less fashionable today. But if you look at this, look at how you can see as you cut through this thing where's tumor and not tumor. I mean, that's getting to be healthy tissue, and then you're cutting here, and you can see the tumor separating. Using a little third hand here to help deliver that, trying to save the false vocal fold. I think you're a believer in that as well, Chris.
Yes, sir.
I know that our rehab team certainly is going to appreciate that. You know, you can have a pretty big glottic defect and not have any significant swallowing difficulties at all. So I'm cutting down and looking at that just to see, you know, as I'm kind of hitting it, saying, do I think that's anything there or not? And then I always take anterior first, because in terms of the tumor springing away from you.
It really does.
And so I'm always anterior first, and I'm trying to follow this margin. You know, I'm flipping it up, looking at it. Okay, where's cancer? What's my margin? That's how I see it as beneficial in terms of that. Like I said, there's a lot of different ways to do it. I think it's an experience thing. I think once you're doing it, it doesn't necessarily matter, but it's just how I know a lot of people do it different ways. So this is the halfway point.
Nice.
And you can see that tumor right here, and you can see that margin. You see we've taken a significant portion of the TA and that conus. Let's zip on across here. It should start moving faster. I wish we had these endotracheal tubes still. And here we are at the end. We're up to the anterior commissure. We've been able to leave the inferior aspect of the TA, 70-degree, checking the margins here everywhere. And you'll see the cautery posteriorly for the internal branch of the internal laryngeal next to the vocal process, which you've got to have, right? That cautery on it. If you're going to be that deep, otherwise you're going to get into bleeding you can't control. So you got to have the right tools. Now this is 1 week post-op when we typically see them. What are y'all's thoughts here? Anything, Melda, that you're concerned about, or Chris or Heather?
Well, obviously, this is a really the healing stage still, and then I would expect that this person will have significant voice issues, and then I would like to really, if the healing is in the right order, I would probably educate the patient what to expect during the healing process. And then the healing process is somewhat unpredictable, obviously. And then some people do really beautifully and some people might not. But I would expect that the voice will improve as the healing process goes on. And any suggestions as from SLP point of view, I would make sure that they don't try just too hard to make the voice any better, or, you know, so that just be patient with the process.
Are you guys using voice rest on someone like this, Chris, Heather? Excuse me.
Not generally, beyond maybe the first day or so for my practice. Chris, you can comment on your feelings, but I try to get them back using some very gentle voicing early on, just because what we know in terms of scar and aberrant healing. So I try not to have too long of a process of vocal rest.
I agree, and I mean, this is not a delicate microflap procedure, and I think the only thing that I encourage is to avoid any kind of vocal strain, to minimize the rare possibility of any kind of mild hemorrhage, which could not cause an airway problem, but just could delay wound healing. And so I really talked with him about that. I wanted to make a couple of points, if I could, Andrew, just to follow on from the video to where we are. One is I should make a disclosure that I don't work with Luminous or have any conflict of interest with any of the instrument companies that we're going to discuss here tonight, including Intuitive. But I mean, whether we split these tumors in half and get that depth, which I think you showed beautifully, or whether you do it on block, I really like, I think you're using that robotic scanning micro manipulator, the digital AccuBlade, so that we can, instead of having this dot matrix kind of approach to a really delicate surgery, having a wider field scanned laser really allows us to do some, I think, some very quick and also some very precise surgery. And so actually, I just wanted to comment about the technique. I think having that digital AccuBlade, I think, has improved the finesse and the quality, and has minimized the sort of collateral damage of using a typical spot CO2 laser. And then sort of moving from that, it's just sort of remarkable how quickly these granuloma form within the wound. And it's great to have that picture up there. It's very instructive, because that helps us give to the patient a good postoperative expectation of it, just how rough that voice is going to be immediately post-op, and to counsel them as you then show in just probably a couple of weeks how quickly it heals.
Right. Well, that's the thing. You know, like you guys said, I think the voice, you don't want to do too much to disrupt it, but you also no bearing down. I tell them no heavy lifting, because this is what you want. You want this beta granulation to form the infrastructure and the scaffolding for the cord to regenerate. And when you lose that, you hate to get a glottal insufficiency because you don't do it. Those are the cases when you have a bigger endophytic tumor like this and you don't get it, that we start to have trouble in that reconstruction, you know, and what are you going to do? Patients always get a little bit worried when they see a lesion like this. They're like, what's going on in my throat? You know, I tell them it's the scab in the swimming pool kind of thing. It's just a soft scab, and it's going to get better. And then, you know, this quickly progresses on to, you know, a well-healed true vocal fold.
How many weeks out would you say that video is, Andrew?
This is probably 4 or 5 months, you know, and it's going to only get better over time. And that voice, you know, I'm starting a little feedback on that. You know, she's saying it's a 10. I had just the same pictures here in case we were having video trouble. So sorry to give you guys sickness going through that. Let's move forward a little bit more, and let's talk about a little bit bigger tumors that are always in question for us. You know, so I think people are very comfortable today with different techniques of managing T1, laser wavelength, cold steel, radiation, counseling it. Anterior commissure gets a little bit more questionable, especially as we're thinking about voice preservation and what that means for patients as we have this conversation. And these are all anterior commissure squamous cell carcinomas, but they're really different tumors here in terms of what they look like. And I think one of the instructive things is to think about, is this a primary tumor of the anterior commissure, like the two at the bottom, or is this a unilateral tumor that is spreading across the anterior commissure, like the three at the top? And that dictates how I approach these. I'm more concerned about the primary anterior commissure tumors than I am, even though these are, theoretically all T1Bs, maybe a T2 here or there, but how that is going to influence it and how it's going to influence voice. So Chris, I thought maybe you might comment, or Heather and Melda, maybe your thoughts about voice, and then Chris, your thoughts about staging, left versus, taking primary and coming back for the other side versus resection primarily. And then also, what are your thoughts about, I think we can all agree that radiation is going to have a better voice outcome than any surgery we're going to do typically. But then also with some of these tumors, the role may be a supracricoid partial laryngectomy, with your expertise in that, Chris.
Absolutely. Absolutely. And I think it's really helpful to have the full spectrum of disease that we actually see, because we have a staging system that woefully inadequately addresses the significant differences in biology that we see. And I think Melda and Heather were talking earlier about patient expectations and how important their voice is to their quality of life, if they're a voice professional or not. That is a really important consideration. But I also think age is a really important consideration as well. And I think that I think hands down, one of the most important aspects of choosing laser surgery is to minimize late side effects. We're going to talk about that in the oropharynx a little bit later in the hour. But, as much as I see the value of operating on certain patients like this, I also see the value of radiating a patient who might not benefit from the avoidance of those late side effects that we're going to see in a 45-year-old who has an anterior commissure lesion versus a 65 or a 75-year-old. So even beyond these pictures, I think incorporating age as well as an estimation of the biology is really important in decision making. And I should probably stop there to let Heather and Melda chime in, and there's maybe some other details we can discuss in a minute.
I think, here in this patient, in this kind of images, I think what the patient really wants and what they want to do is I would like to think that it should be somewhat driving force about the choice of the treatment. Because as you said, if they want to, we have some patients that they would like to, regardless of their age or their, voice, and they just want to be done with this very quickly and very instantly. And then with this, with the knowledge of the voice issues, they go that path. But if sometimes they would say, no, my voice is everything, then that will determine different really treatment strategies. So I'd like to think that here, what patient thinks and what the patient really needs, and how quickly and how often how quickly they want to deal with this. And then I think our role is give the patient the best education about the both options, outcomes, and then let them really make the decision somewhat. What do you think, Heather?
Yeah, I absolutely agree. And I think, especially looking at the two images at the bottom, those are people who I'm worried are going to have a major keyhole defect. Their voice is not going to be an excellent outcome. And I think these are the kinds of patients where we have to keep in mind, too, that the radiation that's offered for a patient with a small glottic cancer is not the kind of radiation that's causing these major late radiation associated dysphasias that we're seeing in some of our other populations. And so I think that, talking with the patients and finding out what their priorities are is always important. But in this sort of a case, when you see those larger anterior commissure defects, I think from a voice perspective, I do get more concerned particularly if voice is important for them.
I'll tell you that I find these very unpredictable. Sometimes I'll tell you that the three at the top, or the first two here, were both staged. The one on the right was a big resection. The bottom was radiated, and I really, really wanted this lady to radiate because I think this is the most dangerous tumor up here. You can see this extremely endophytic, and she didn't do it. I essentially did an endoscopic supracricoid, taking all her cartilage. She still ended up with a total laryngectomy. All the rest of them were in good shape. But, you know, you may get a big web that may be beneficial. Or dealing with anterior glottal insufficiency can be a tough problem. I thought maybe I'll move over to the next slide. I'm not going to go through all the videos because time is flying by here. When we're talking about laryngeal cancer, I just have too much fun. But the timing of voice and thoughts afterwards. So this is the same tumor, big tumor here. I'll just play the whole here a minute. So good resection of most of the left. You can see the tumor up here at the top, all through the anterior commissure. And I won't even play voice, but I'll just play you. Here's 1 week.
Just gently breathe and try not to swallow for me.
So big beta granulation.
I'm almost done.
Chris, Heather, thoughts about voice rehab in a guy like this? Melda.
Oh.
Anyone?
Yeah, I mean, obviously there's a period of time of healing that needs to happen here. We have to respect that to some extent. But I think, you know, it's sort of similar to the last patient that we mentioned. I think that there's a role for early gentle voice work with limited amounts of voice use, but certainly very judicious voice use. We wouldn't want this person doing anything that's very aggressive, especially early on in terms of their recovery.
I agree.
Yeah, and I think the final point that I was going to make, as maybe we wrap this up, I'm sure this is preaching to the laryngology choir, but I think hopefully there are some of my general ENT colleagues on as well. And you know, these anterior commissure lesions, not the superficial ones that you showed, but some of these really bulkier. This is the cancer that really does need to get that CT scan. You need to assess and make sure there's not cricothyroid adenopathy and that the membrane is intact before you embark on these sorts of things. But sort of a nice result there in the end, Andrew, but a long journey. And so I think you've got to have a very motivated patient who really wants to avoid some of those potential downsides of radiation when you tackle these anterior commissure lesions.
No doubt. This is 1 week. This is 1 month. This is 8 months. You know, and so we always run to this question, you know, do you intervene on this web? Do you take granulation tissue out early? I'll tell you, I've certainly got burned at some point over the years of taking it out and then having some glottal insufficiency. I'll play this voice up here 1 second.
Ready whenever you are.
You ready? The rainbows of the vision of white light into many.
That quite honestly is better than his pre-op voice. So the reason I went ahead and played that was just to say, don't be scared of the web in some of these people. Sometimes it's a good thing.
I think working with these patients as an SLP, I realized that, you know, that web doesn't necessarily mean really awful voice or unacceptable voice. We have several patients that with that web, they put their voice between 8 and 10 out of 10. And really, if you listen to them outside the clinic, you would never think that they have a web. So it is the voice quality is incredibly sometimes unpredictable.
Chris, can't hear you, bud. Chris, you're on mute.
Apologies. Andrew, educate your head and neck surgery colleague here. How often would you need to go back in and analyze a web like that for a symptomatic dysphonia? Just estimate for me.
Almost never. And I actually think it's amazing how little vibratory folds you need to have a reasonable voice. And what I've learned is that anterior glottal insufficiency, if you make it look pretty, doesn't equate with a better voice. It matters what it sounds like, not what it looks like in these cases. So let's move over to, and so the things we work on with these guys, speech pathology, really quickly before we leave, because we're going to leave glottis and most of larynx cancer. I think Melda would tell you that we're working on pliability exercises primarily.
Yeah, pliability, as much as they can do that, and then also avoiding any other, environmental issues that, might contribute to the voice quality. But really, basically, we are bound by the tissue, how they heal, and then try really hard to make the healing process as good as possible.
Okay, let's, sorry. Supraglottic cancer. This is a T2. What amazes me with some of these people is that they can be somewhat unpredictable. This is all tumor coming down here, coming down onto the vocal folds, actually. As we look down here, he's got disease here. It's a guy who didn't want radiation. What are y'all's thoughts? Let's change tack. I know there's some glottic involvement here, and I've come way back on this guy. Heather, thoughts on swallowing and what you guys are doing, preoperative swallow study, expectations for the patient, prophylactic therapy ahead of time. Give me your diatribe on what you're telling the patient.
Yeah, so these are patients I think it's really critical that we get a preoperative swallowing evaluation on. We really need to understand what their baseline function is. And at that point, oftentimes I like to do a FEES for these patients because it also will allow me to teach them the compensatory strategies that are likely to be necessary. So we can use the FEES as a biofeedback mechanism to have the patient understand what it looks like to get their vocal folds closed before they swallow, so that they can sort of master that technique before they actually have surgery. I find they tend to rehab a lot quicker if they're fully prepared for that. And then preparing them just for, depending on the extent of the surgery, which obviously would be a discussion with our surgeons, preparing them for a period of time that could be as little as 2 days or as much as 2 weeks, depending on the surgery and the surgeon preference of not swallowing. But we want to get that patient back to swallowing as quickly as possible, even if it's on a limited diet to begin with. So definitely advocate for pre-operative evaluation and counseling for the patients.
I agree with you totally, Heather. I think that's invaluable. Setting the right expectation and assessing what the availability is of the resources for support for this patient, is really significant. And this, I think, Chris, we can tailor this operation, right? We would never be able to do a traditional supraglottic this way. We can, following the tumor, and get this superficial disease. You see, I left a lot of the paraglottic space here because it was a very superficial tumor. The problem that we run into with that in my experience, is that sometimes we'll end up with a stenosis picture, a little bit like you'll see down below, compared to a traditional supraglottic. Any thoughts about this in that regard?
Well, it's the value of doing a truly personalized precision head neck surgery that you've done here. And where the disease is superficial and you can divide the depth, you can minimize the collateral damage that you do, but more cranially, you can take the entire epiglottic cartilage when need be. I just wanted to make 2 comments about this case. Probably the most important selection criteria of this case is right there in letters. This patient is N0. I think to have a patient who has no likely need for postoperative radiation therapy, so that all the rehab is really in the hands of Melda and Heather, gives this patient a really good chance for getting good cancer control, and then also having a good functional outcome. So I think, letting the neck help you decide which patient you operate on is just really critical.
Right. I agree. I'm going to jump ahead. You can see the big hole here. I just want to show here in part of this rehab, because these patients, so a guy like this, are you guys going to put a G-tube in ahead of time?
No.
No, sir. No, sir.
No.
Well, see, I'm totally the opposite. On a guy like this that I'm going to do, I'm going to do it. Because, I have guys who you save the epiglottis and they don't swallow for 3 months. And you have a guy like this, he might leave the hospital and, with neck dissections in 2 days swallowing. It's so unpredictable.
That's a
Well, I
good.
tell you where.
I think one of
Yeah.
the things is that preoperative evaluation would probably lead me maybe one way or the other. Also thinking about other factors like general health status, comorbidities, age, family support, all of those sorts of things would weigh in. So my emphatic no is tapered by reality.
There you go. I bet
what-
you the only way we'd all agree is if this patient were a failure, a radiation or a chemoradiation failure. I put a peg in every single one of those patients.
Absolutely. It's a long
Yeah.
road.
Yeah.
I wanted to show this part because as Heather was talking about the value of biofeedback here, and I think that fees and biofeedback in supraglottics is immense.
Yeah, beautiful.
And so then there's that squeeze versus the hard breath hold, that's going to get him swallowing. That's 4 weeks right here. This is a 6-week swallow, and here he is afterwards. So we're going to spend too much time on all this. TLM, I guess the point is big tumors and prolonged time for healing, just like you talked about. You can have a bigger section, and these people take a really long time. This is a very different patient in terms of the rehabilitation, having that feeding tube up ahead of time, long time to heal. We keep antibiotics going. Obviously, they're aspirating, worry about superinfection, and it takes a long time. You see the clips, all this. It's a very different looking larynx. Here's our fees, all of these roles in this, but to get these patients to the other side.
And Andrew, I see a question from, I believe it's Dr. Rosen from just up the peninsula. Did you do a neck dissection on this that T0, that T2N0 supraglottic patient?
Yeah, so I do. And I talk to the patients about PET imaging and close CT monitoring. But I think the safest thing, I have the conversation with them that it is that the safest thing is to know. We'll know when it's in the box a lot better than we'll know otherwise. It's definitive in that regard.
I agree. I mean, I think all of these patients need, at least in the United States, I think they need bilateral neck dissections. I think in Europe, you've got an expert like George Lawson doing sentinel lymph node biopsy for things like this. Not as widely used in the United States, but I think, you're going to salvage this patient and they'll survive if they have a local recurrence. But if they have a regional failure, oftentimes that's where we actually lose with this disease. So I think good discussion point there.
Yeah, no, absolutely. We could, with this thing, we could spend a lot of time on all of this, I tell you. Just closing points on conservation laryngeal surgery, just to Heather's point, patient selection, their personal commitment to rehab, having the rehab team intact so that we can have those resources, family support, in terms of they've got transportation, they've got people on their side. And I actually Botox the UES on all of these people to help facilitate their swallowing.
I think with these patients, really, one of the most important thing is, their understanding of the process of rehabilitation. And then also, I think, really we have to understand each patient individually and everybody goes through rehabilitation very, very differently. So in one patient, we can have very quick result, but in another one, even though excision might be a lot less, they might really take quite long time. So looking at those individual aspects of the patient might really help with the, rehabilitation process.
We're going to change over to transoral robotic surgery and surgery of the oropharynx. Like I said, time is going on us here. And Chris is one of the leading experts in this process. And so, Chris, I'm going to turn it over to you. This is actually Dr. Holsinger in the console here. And of course, human papillomavirus. Chris, I'm going to move forward for you here. Oh, Chris, you're off again on your sound, buddy.
Thank you. Thanks, Andrew. You can go ahead and advance again. past the intro. Well, I think where larynx cancer remains really a no-brainer for a lot of early stage disease, there's still a little bit of controversy surrounding the management of oropharynx cancer. And I thought Heather and I would present a case tonight to really highlight some of the speech and swallowing issues and also cancer management of these patients, because I think many of us still come to the multidisciplinary clinics really with the expectation that, hey, the standard of care for head and neck cancer is some sort of radiation-based treatment with or without chemotherapy. Next slide, please.
Okay.
And this is a problem. In fact, Andrew, I'm actually going to request remote control. I may try to drive here myself. In 2019, this is a significant problem for us. And in fact, as larynx cancers have sort of plateaued around 13,000 cases a year, there's been, as this paper from Chaturvedi et al. From 2011 cites, a significant rise in the rate. And just that the actual rate of rise is actually pretty remarkable for this. So Andrew, I may be driving it backwards. I'll hand this back over to you, my friend.
Come on, Ben.
So in fact, there's been a 225% increase over the last 25 years. You see there in this article, in this slide that quotes that Chaturvedi et al. From the previous slide, as well as the New York Post, highlighting the HPV-related throat cancer of Michael Douglas. And if this rate of rise continues, it will be a significant health problem among men, second only in non-smoking men to a prostate cancer by 2040, according to Eric Sturgis at MD Anderson. Next slide. There's good news and bad news. The bad news is that these cancers are on the rise. The good news, as you see here in this 2010 New England Journal article, is that the outcomes from these HPV-related throat cancers are vastly superior. The number that I use is 25%. So when I see a patient who comes in and we're discussing treatment, talking about voice, talking about swallowing function after radiation or surgery, I take them right to this table. And for all stages, and in this paper, you have T2 and T4 lesions. The overall survival for HPV patients, HPV-related patients, is actually nearly 83%. That's 25% better than the HPV negative cancer. And so I think this study and that table, I think, is really important to bring into that patient exam room, into your tumor boards. Next slide, please. And as we discussed a little bit in larynx, I think age has a significant impact on treatment decision-making. Late side effects that we're going to talk about next are a central driver for the selection of a potential de-escalation strategy or minimally invasive strategy. And you just want to compare how things have changed in my own career. I was a medical student in 1991 when the VA study was published. The average age in that study was 62 years. And in the Marshall Posner study, and then in this 2007 paper that looked at oropharynx cancer, the average age is now in the mid-50s. And so with the next slide, you'll see that it's not, I try to avoid this us versus them, surgery versus radiation dialectic or sort of battle. It's a false battle. What we want to do is really choose for this patient the best option that gives great cancer control but good function. And there's a high rate of long-term toxicity the younger you are when you get that full dose radiation therapy. Late toxicity, greater than 5 years, as was reviewed in this paper, was found to be 43% in this early study that looked at 9111, RTOG, 9703, and 9914. Next slide. My colleagues, my critical partnership at Anderson with the speech language pathology team actually laid the foundation for, I think, allowing us to move a treatment like TORS ahead to the forefront. And I'm going to just sort of skip over this, but the bottom line is if you get full dose radiation therapy before the age of 55, 10 years later, a very high fraction of those patients are going to have silent aspiration and significant cranial neuropathy. Next slide. And so really, I want to avoid that us versus them and focus on, you know, how do we minimize toxicity and maximize cancer control? Next slide. Now, having said that, it's important to understand that surgery is not the only innovation. Refinements with IMRT, intensity modulated radiation therapy, and proton therapy, next slide, might be an important way for us to manage them. But I'm going to talk a little bit about transfer robotic surgery and just sort of fly through these slides here. We've got about 13 minutes. Yep. This is really important to understand good practice in terms of doing the surgery, but also in selection, because so many of our colleagues in otolaryngology are actually choosing this option, a primary surgical approach for their patients. Jane Cracchiolo is now a junior faculty at Memorial Sloan Kettering, and she reviewed the National Cancer Database and looked at treatment decision-making for T1 and T2 patients over the years of 2004 and 2013. And you can see around 2009, and this was the time when robotics was approved for oropharynx cancers, and the robot was approved for T1 and T2 tumors. There's a significant divergence in the way treatment selection was made. So essentially, patients almost 80% of the time for a T1 lesion now are having some form of surgery. And you know, back when I was in medical school in the early 90s, surgery was not really even being considered, at least at Baylor where I was training. Next slide. So a significant sea change really in the way we're treating this disease, brought on by HPV and the differing epidemiology, but also technology has allowed us to do better work for them. So want to draw your attention to this quick study, the study that was published in 2015, 410 patients over 11 different academic centers underwent transforaminal robotic surgery. Next slide. Very high rates of local regional control and excellent overall survival, comparable if not better than chemoradiation. It should be noted that this is a multi-center retrospective review, so it's subject to a recall bias and a lot of other factors. Next slide. And so I think in the next year or so, you're going to hear about ECOG 3311, which is a prospective clinical trial to answer, so I think, some critical questions. And I think hopefully there'll be time later in the hour for us to tackle them. So just to wrap up this oropharynx section, I wanted to focus on this case presentation that I think will highlight a couple of these issues. This is a patient we saw in late last year. He was 49 years old. He'd had this sort of vague history of Globus and no real lesion was noted on cursory exam. Finally, he was referred to an otolaryngologist who found a neck mass, and a full evaluation was performed. It should be noted this patient had diabetes mellitus and hypertension, and he's had no previous surgery. Next slide. Heather, I'm going to maybe turn this over to you. I think this is your endoscopic video. Why don't you take us through some highlights of your exam, both in terms of the extent of the tumor and already what you're thinking about functional impact of treatment.
Sure. So yeah, I think this was a joint exam, so we'll see the narrowband imaging that you would have been using and then the swallow after. But you know, one of the first things that we can see is that, you know, this tonsillar lesion is extending pretty far, all the way almost from the nasopharynx all the way down into the mid to lower pharynx. And so one of the things I start thinking about when I think about radiation with these patients is this very large tumor is going to require a radiation field that's likely going to impact bilateral pharyngeal constrictors. And so we're talking about, you know, the kind of radiation that can lead to some of these late toxicities that Chris mentioned earlier. The other thing that I think about when I'm looking at these tonsillar patients is the degree to which the soft palate is involved and the degree to which the soft palate will need to be resected, because I think that some of the most terrible outcomes I've seen in terms of function after TORS have been related to resection of the soft palate and velopharyngeal insufficiency, which is very, very hard to manage in some of these patients. But what we see in terms of function on this as we get into the swallowing portion is that this individual, though they have a very crowded pharynx and not a lot of space, he's able to swallow quite well. You can see there's a tinge of blue there at the very posterior aspect of the larynx, but the baseline swallow function is quite good. And so this is a patient for whom a functional perspective, a robotic surgery may be the better option for this individual because of the type of radiation that would be required.
Right. Well, thanks for taking us through that, Heather. And, so Heather and I actually see patients oftentimes concurrently in our clinic. And so, in fact, in our multidisciplinary clinic, actually, I'll actually start the scope, kind of do my staging. You saw there the narrowband imaging. It's helping me to see the edges with that blue-green filter. And then I'll just hand the scope over and she'll do the feast. I love that format. It cuts down on cost and charges, and is certainly a lot nicer for the patients as well. If we could go back maybe just one slide, and I was going to highlight one more thing. This is a very exophytic tumor. I'm going to point out over here on the right, on the right oropharynx, or the left side of the screen. This thing is just pooching out into the airway. And it's just sort of begging for someone to sort of operate on this. There's only a hint of submucosal disease as it extends up into the soft palate, and it's completely separate from the tongue, as Heather showed you with her scope. However, one of the most important things that I recommend, and it's hard to show this in a video, is that tonsil needs to be mobile from the underlying constrictor. One of the last things you want to do is get in there and get deep to the constrictor, do a safe surgery with regard to the carotid. You can go ahead and advance now, Dr. McWhorter, thank you. And then find that you can't clear that deep margin in the parapharyngeal space. Tumors of the tonsil that are mobile with your finger in the exam, I think, are really ideal for this approach, no matter how big they are, I mean, within reason. And this is a physical exam finding that I then take to the high resolution CT scan that you see here that helps me really determine whether or not this patient is a good candidate. And you can see here there's a nice sort of plane, and this pterygoid muscle in parapharyngeal space is relatively preserved, and you see no avidity there on the PET scan. So I'm going to sort of wrap up here, but the final point I'm going to make is that this patient has relatively encapsulated neck disease in the way that I don't want surprises deeply in the parapharynx so that I can optimize my functional and oncologic outcomes. I don't operate on patients who have obvious extranodal extension. And this is a gentleman who used to play rugby, has a big thick neck. It's hard to feel if that's a single node or a matted collection of nodes. And so I think having really detailed imaging is really important for decision making. And so we find using AJCC 8th edition, this patient was stage T1N1. This was a right tonsillar lesion, P16 positive, and in addition to the joint visit that we had, Heather and I, patient saw dental and medical and radiation oncology all on the same day. And we had a long discussion about this patient. Should we go for an upfront resection, neck dissection, or just give him 70 gray with concurrent cisplatin? Andrew, any thoughts there, or Melda or Heather, as we sort of do a little miniature tumor board here in the final 5 minutes of the hour?
Right. I think the importance of the tumor board presentation, having this patient have all of their information weighing in from vet-onc and rad-onc is really important. I agree with you, Chris. I'm going to move you on over to your specimen here so we can try and get through really fast.
Fantastic. So this patient went on a head surgery. I try to orient these specimens and use the margin marker so that everybody is on board with what's a good margin, what's a close margin, what's a positive margin. The deep margin is tricky. This patient, in fact, had a very large lesion. And I'll tell you, by the way, I did not want to operate on this guy. He had diabetes. I was worried about secondary healing. But he was 49 and did not want to have those late effects of radiation. And we were able to, I think, hopefully in the short term, pull off a good result for him. This was a large tumor, almost 4 centimeters, almost T3. only 2 of those nodes, you saw them on the CT scan, were positive, and most critically, there was no extranodal extension. So next slide. This patient was able to go on and have single modality postoperative radiation, both for the size of the tumor and the nodes. And Heather, why don't you take us through his postoperative day 2 feast?
Yeah, so you can see, I know this is very early in terms of his recovery. He has an NG tube in place. He's got a lot of swelling, and as you'll start to see as we get to the point where he's swallowing, you can probably skip ahead in part of this video. He doesn't have perfect clearance in terms of pharyngeal clearance, and he does have some overflow there into the laryngeal vestibule. But what we were able to do over the course of this fees was to teach the patient compensatory strategy. So tilting his head to the left to get the bolus to go down the better side, having him do volitional throat clear after the swallow. And with these strategies, he was actually able to initiate a puree diet with thin liquids on post-op day 2. And so we feel really important that it's really important to get these patients swallowing as early as possible. Again, trying to optimize function and minimize potential for scar and tethering.
That's great.
And yeah, no, thank you, Andrew. Any comments from you, Andrew or Melda?
No, I think the idea of early mobilization,
Yeah.
we like that idea, just like we like that with the larynx and, you know, helping these things do to prevent scar and get that going. I think that's great. Any parting thoughts on this? You want me to skip on, Chris?
Yeah, so this is our most recent modified barium swallow that Heather's going to take us through. He's about 6 months out from treatment, no feeding tube, and doing well, free and clear of disease.
Yeah, so you know, you can see on this swallow valve, which is done after his radiation, that he's actually swallowing quite well. He's got very limited trace levels of residue in the vallecula and along the tongue base. A little bit of penetration that's transient. Most of what you see with him is edema of the arytenoids and the epiglottis, and this is a gentleman for whom I'm actually working on lymphedema with him as his primary treatment right now to try to get some of that controlled, both internal and external. But he, at this point, is on a totally normal diet without any restrictions and no complaints about his swallow.
Heather, you know, and Chris, I saw that you were able to de-escalate and only give him 60 gray instead of 70 gray and try and get below that threshold. We're running out of time here, but as we talk about radiation and swallowing, he's engaged in a swallowing therapy through radiation here?
Absolutely. So we are very proactive in terms of rehabilitation. We get them started on exercises before radiation starts, and we have them completing exercises twice daily all the way through radiation. And for at least the first 3 months post-radiation, we try to get them to continue on. But at the very least, we try to keep them going for those first 3 months during acute healing.
I think that's really great that you're initiating ahead of time and continuing it afterwards to try and, you know, and bracket this and really work through these phases of early fibrosis. I think those are really key points that we would have been bringing out in the next aspect of our talk that we're running out of time for. You know, we all know about this question of organ preservation versus function preservation. There's, you know, toxicities as well as these other problems. We know that dose and site, all these things matter. You know, we're trying to, whether this is through swallowing, but, you know, regardless of what Cochrane database says, I think it's just bad data. It does work. There's different factors that are in play. I think the big thing is adherence. I know you've talked about adherence before in terms of, you said people working twice a day, you're engaging them ahead of time and as well as afterwards, that patient selection of what they're going to do. You know, it's all over the place when you look at what the standard may be. Some places aren't getting any. You know, we saw a neuroendocrine in the larynx today who got treated elsewhere and had no therapy, or you got it all the way to, you know, 5 times twice a day in the pharyngicize. And I think that the data is going to show eventually that there is some critical component of where we need to be as we're trying to figure this out. Quick point of it's more than just swallowing. You know, this is Melda's work talking about how people who do exercises do much better than swallowing itself. And it's, you know, weight loss, there's a lot of things that go into this, not only about the G-tubes, but also how much better they do in the long run in terms of what diets they're able to regain with prophylactic therapy. So as we finish this up, just going back to you guys on tools and technology, engagement of the patients, if you could just help us close this out, Heather.
Yeah, so this is a publication on a feasibility study. We created an app. This is a project that's been about 7 years in the making. So we did a feasibility study using an app to support patients for their exercises during treatment. And we're actually in clinical trial in conjunction with Hopkins and Harvard at this point, with a really nice, robust app that will provide patients with workouts and videos and lots of other support mechanisms.
I think that's great.
That's wonderful.
Are you guys using telemedicine at this point?
Not much, unfortunately, no.
Yeah, we've been trying to do that, and our carriers won't pay for speech pathology.
Exactly.
Here is our problem. There's nothing like good old-fashioned exercise. Any of these things that we should talk about as we close in terms of these specific tools, or just swallowing therapy in general?
Sure. I mean, I find myself using the EMST more and more with my radiation, especially my late radiation patients who I'm not going to change their fibrosis, but maybe I can change their reaction to their aspiration. And I think there's been some nice preliminary evidence from Kate Hutchison at MD Anderson using EMST in head and neck patients. So that's become a big mainstay in our clinic. We certainly use the IOP for biofeedback for tongue strengthening and CTAR as well. So I think, patients tend to be more adherent if they have a tool that they're working with. And so when the tool is an appropriate tool to use, I would definitely advocate for using that.
Okay.
I think we have, we've learned really so much, and then our therapy approach is really evolving towards these patients. I think, more and more tools and are becoming available for us. Hopefully in the near future or in the coming years, we will find out, how much really is good enough. What is the minimum amount of exercise that these patients have to do so that they can maintain the function, or how often, So I think, hopefully in the future, we will know more about the dosage and the intensity or frequency of these exercises. Hope that we can be all on the same page and maximize the function in our patients.
Before I close this out with this continue the conversation, we had two questions. One was set protocols for voice and swallowing exercises, Melda. Do you have a set protocol?
Well, we don't. It all really depends on first. You have to find out about the dysfunction, and then what the patient really needs, and try to gear the exercise towards that. But we really like we like addressing the base of tongue or pharyngeal and of pharynx, and then upper esophageal sphincter. And those are the ones that we focus on very much. But obviously, your protocol mainly will be driven by patient's pathophysiology of the swallowing dysfunction.
And one last question was from about, do patients pay for EMST out of pocket, Heather?
Yeah, unfortunately, right now, that's how we manage it. So since we can't bill for them in our clinic, we don't have the ability to do so. I will just show the patient how to order it, and they pay for it out of pocket. Okay.
So we're going to close out this session, and we appreciate all the viewers who listened in. I'm sorry we didn't spend so much time as what y'all thought we would on prophylactic swallowing therapy. Chris and I kind of hijacked it with our interest in surgical management, but hopefully something beneficial in some of that. There's an opportunity to continue the conversation. This is really a neat tool. I'm excited about it. Clark and Al have reached out to me about this and make sure that people are aware of this. Really a unique opportunity with this online discussion forum for, like I said, questions and these things. And Clark and Dr. Rosen and some people will potentially be available for some other questions or anything else ongoing after this closes. And the webinars, not only available through the Fall Voice, but are also going to be available through this discussion community access that you all have access to as attendees of Fall Voice. So Chris, Heather, Melda, Dr. Adkins, the silent partner, thank you guys very much.
Thank you.
Thank you.